Hi, good afternoon. Welcome to all. I'm Christo Kloppers. GECKO is hosted by Gastro Foundation in association with Project ECHO, University of New Mexico. We run this GECKOs on every Monday at 16:30, and the chat at the end will be open for questions. I'm going to slowly start. Today I'm going to talk about cystic liver lesions, and we'll go through a couple scenarios. Let me see if I can get this thing running. So on the talk we're gonna go through the different differential diagnoses of cystic liver lesions. We're gonna stand still a little bit on mucinous cystic neoplasms of the liver, and the differences between recent or fairly recent classifications. And we're going to look at different algorithms for cystic liver lesions. Obviously, there's a pathology-based one and an imaging-based one. And then we'll discuss a few aspects around Adaptations. I know this is a difficult sometimes online, but I think it would be nice if we can try and make it interactive. Otherwise, I'm just talking to a screen here. I'm not going to pose any queries at individuals, but if you've got opinions or comments or questions or anything to add, please do so. And then maybe we can have some discussion around it too. I'll try to keep an eye on the chat. Otherwise, we'll address to that at the end of the meeting. Okay, so if we look at cystic liver lesions, these are the two big groups. If we ignore Biogenic and amoebic liver abscesses for the moment, obviously that's important, but we'll talk a little bit about that in the end. Most of them are imaging based, so let's look at the first one. It's a simple cyst, and it's exactly what it says. It's simple. Normally, it's that size. Simple cyst is solitary. And you can see what it looks like macroscopically at that picture below. The middle group is Adaptations, which is a specific disease which we'll discuss. It's a parasitic disease. You can see on that CT scan in the middle, that's often the case with big cystic lesions, and that pertains to biliary mucinous cysts too. There's a little bit of central biliary dilatation, although this patient probably does not have clinical jaundice or biochemical jaundice. There's often a little bit of central biliary dilatation, and you can see some specific characteristics of Adaptations disease in that cyst. We'll look at that later too. Again, in the middle, you see a microscopic picture, and it's that shiny white. It's often a pathognomonic of Adaptations disease. And then the rare one at the end, which we'll discuss separately, is the biliary cyst adenomas, and as they used to be called, or biliary cyst adenocarcinomas, and this is complex multilocular cystic lesion, almost always solitary, that you see in females. Macroscopically, the picture on the right, sort of a complex cyst. It's always a difficult cyst. It's almost always engaging the hyoid structures, which makes them tricky to treat surgical. Okay, so let's start with simple cysts. I don't think there's too much to say, but we can talk about it. Simple cysts of the liver are cystic formation containing serous fluid, and they should not or cannot communicate with the intrahepatic biliary tree. They appear simple macroscopically and on imaging, unless there was intracystic bleeding, which could happen, or previous sclerotherapy. That brings us to the treatment of them. Majority of them, a far majority, does not require any treatment. You do sometimes want to select those who have who's symptomatic, that you can potentially treat. One tip there is, and we do tend to do it, if you think the cyst is the cause for symptoms, upper abdominal discomfort or pain, pressure symptoms, you actually need quite a large cyst. I think most people would agree a cyst smaller than 8 centimeters are unlikely to give you symptoms. And the symptoms without cyst without pressure effects on imaging is also unlikely to give you symptoms. So unless it's compressing a structure around it. But you can aspirate the cyst or even drain the cyst percutaneously, not as definitive treatment, but as sort of a test of treatment. If you would do operative treatment, whether it would affect or resolve the symptoms. Sclerotherapy is well described, mostly with ethanol. I have no experience with it. We tend to, as soon as a cyst is proven to be symptomatic or a very large, simple cyst, normally it's quite easy to do just a simple deroofing of the cyst, and we will mostly try and do that laparoscopically. You deroof the cyst and deal with the problem that way. On the same topic of simple cyst is polycystic liver disease. So that is a genetic disorder responsible for progressive development of multiple cysts in the liver. It could either be part of kidney disease, so autosomal dominant polycystic kidney disease, or without a renal involvement, and then it would be autosomal dominant polycystic liver disease. They're both obviously linked to gene mutations, so they're both autosomal dominant. And they almost have the same clinical cause. Important to note that renal cysts are actually quite common. So even if you've got isolated polycystic liver disease, you might still have 1 or 2 renal cysts, as those are just common. Let's just look at the treatment of these specifically. It's not a common thing being treated surgically. I think there's more than one classification for that. This is sort of one useful one. I think classifications to try and remember names are sometimes so difficult, because unless you know the classification, it's not so important. Rather describe it. So a type 1 would be less than 10 cysts with large area of non-cystic parenchyma, as you can see there in picture A. There is some cysts, it is clearly less than 10, but there's a lot of preserved normal liver parenchyma. Type 2 have diffuse involvement of liver parenchyma by medial-sized cysts, the remaining large area of non-cystic parenchyma, so there's still some normal liver left. And type 3 is massive diffuse involvement of liver parenchyma by all sorts of size cysts. There's not a lot of normal parenchyma seen in between. So the treatment for polycystic liver disease, you would not often treat them, but if they symptomatic, open fenestration used to be the standard therapy. Technique is simple deroofing and the widest possible excision of the accessible cyst wall without interrupting the liver parenchyma too much. Sorry, I jumped a slide now. This could be done laparoscopically too, although sometimes it's quite tricky to find these cysts, especially in a deformed, stuck liver in the right lateral or so in 6 or 7, or even in a high up segment. So it could be done laparoscopically, but I think you need to know exactly which cyst you're going to target in those cases. Resections, I must say that again is something that one doesn't embark on often, but if there's an area of the liver, mostly would be the left lateral segment that's more involved with the cysts, you could potentially resect that piece or that segment or sector of the liver, and not influence the hepatic remnant. It's important to remember that these patients, is unlike renal disease, where the end state of disease is renal failure. These patients normally do not progress to hepatic failure. It is more a pain issue and a septic issue. So I've got this slide here. Not that this is something that you should embark on. So Starzl, the godfather of hepatic transplantation, did say it's a syndrome of lethal exhaustion. So you should only consider that in patients who's got severe cyst infections, portal hypertension, ascites, and cachexia. But in reality, it's unlikely something you would do in isolation. It is, if you look at the series, and it's small numbers that has been published, it's normally in combination with patients who need or renal transplants, and in that way you can justify the immunosuppressions. I think we'll walk off from that for now. Is there any comments or questions on specifically on simple cyst or polycystic disease? Can you guys hear me? I hope so. All right, let's go on to mucinous cystic neoplasms of the liver. That is that right-sided picture we've shown in the beginning. So it's a cyst-forming epithelial neoplasm, usually showing no communication with the bile ducts, composed of cuboidal to columnar mucin-producing epithelium with ovarian-type substroma. It is almost exclusively in women. If you read about this in the literature, there's always some argument about it. I think if we look at the histology just now, it in actual fact is exclusively in women. It's categorized in the basis of the highest degree of atypia, like similar to the cystic lesions in the pancreas. So it's mucinous cystic neoplasm with low-grade dysplasia, intermediate-grade dysplasia, or high-grade dysplasia. And then you get mucinous cystic neoplasm associated with invasive carcinoma. It can occasionally occur extrahepatically, but this is already a rare disease, so it's almost exclusively in the liver. If we look at the histology slide of it, and you'll see the arrow is there in the ovarian-like stroma. So it's got the, for that reason, there's always an argument between pathologists. It actually can only, the specific pathology as described can only occur in women. So if we just look at the nomenclature, which has changed in 2010, but you'll be surprised if you read around it, and I'm sure you've seen that the majority of even pathologists still refer to the 2000 nomenclature. It used to be, as you would remember or might remember, biliary cyst adenomas, and if it was malignant, biliary cyst adenocarcinoma. It changed a long time ago in 2010 to those names you see in the middle category, very similar to that of the pancreas. So it's a biliary cystic neoplasm, biliary mucinous cystic neoplasm, which can either be non-invasive, that's the pre-malignant ones, or what you think is pre-malignant, and then the invasive one. And again, similar to the pancreas, the invasive ones is, this is a pre-malignant lesion, and if it's invasive, it's an adenocarcinoma. The key features of these lesions is in the right-sided column. You need ovarian-like stroma, and you cannot have bile duct communication. So there was a lesion not previously classified if you have no ovarian-like stroma, but you do have a bile duct communication. Remember, it can't be a simple cyst. As we said, simple cysts can't have bile duct communication. So there's an intraductal papillary mucinous neoplasm. Similar again to the pancreas, so a biliary IPNM. There's in one group that is a problem. If there's no ovarian-like stroma, no typical bile duct complication, but just not simple, there's not quite a category for that. So we're just going to go stepwise through the pathological classification of cystic liver lesions. Most digestive diseases, we use the WHO classification of tumors, which they sort of revise every 7 years or so. If you try and find these books, you never can, because it used to be not accessible online. But you can go to your pathologist, and they normally would have a hard copy. So the one we currently use is the 4th edition. and it was published in 2010. I will look at the cystic liver lesions of the liver, and they first divided epithelium line and without epithelium. So we'll go to the one side first, epithelial line tumors, and they could be then neoplastic or non-neoplastic. Remember, this is a pathological classification. On the neoplastic side, on the malignant side, it could be undifferential sarcoma. That's normally in children if we talk about liver, or a cystic generation of any tumor. The ones that spring to mind is neuroendocrine tumors, HCCs, but it could be any tumor. Benign ones, funny enough, hemangiomas do get classified as a cystic liver lesion, pathological, hamartomas, and again, cystic generation in any benign tumor. On the non-neoplastic side, so that would be mostly your infective stuff. So with a laminated wall, it's a hydatid cyst, a parasitic infection, inflammation and necrosis, different type of abscesses, biogenic abscesses, amoebic abscesses, also hydatid, and granulomas, and hemorrhagic cysts. Those would be the common ones that you see, those three abscesses and obviously hemangiomas, although most of us won't think about a hemangioma as a cystic lesion. If we go to the other side, the epithelium-lined cystic lesions of the liver, as we said, those with simple pathology on the left, it's a solitary bile duct cyst, polycystic liver disease, so polycystic liver disease, and obstructive dilatation of the bile duct, also classified. You get ciliated foregut cysts. Those are rare. I think you will see one or two in your career. It will be very nice slides that you can get from your pathologist. It looks like a duodenum in the liver. And then the lesions we're talking about currently, the mucinous cysts. So you can divide them with ovarian-like stoma. And if there's no invasions, it's a mucinous cystic neoplasm, which you used to know as a biliary cyst adenoma. You get the invasive ones next to it. And then without ovarian-like stoma, IPNM, biliary IPNMs, or intrahepatic cholangiocyte with cystic change if there's a epithelial invasion. Those would be the common ones. Okay, but just to spoil us, then they published a new version, a 5th edition of digestive systems tumor classifications, but luckily there was no change to the cystic liver lesions classification. So take home here is you should refrain from using the term biliary cyst adenomas. It's replaced by mucinous cystic neoplasm of the liver. They should have ovarian-like stroma, and it should be your primary diagnostic consideration in middle-aged women who have a well-encapsulated multilocular cystic liver lesion. It's rare, but you need to consider them, otherwise you will miss them. The diagnosis is extremely tricky to confirm it preoperatively, so that's why you must have a high index in this of suspicion. Cytology or tumor markers, there's been some work on it, but it's not established to be helpful. There's no big series around. Frozen section appears to have a limited role. As a matter of fact, then you've already misdiagnosed it in a way. So I think the frozen section would be reserved for when you stumble across it by presumed different diagnosis. So if we just look at the surgical strategy of these cystic lesions, as I showed you in that first picture, often they are quite tricky as they are large, and they're often central, and they're often complex. But the the only appropriate surgical strategy for them is complete resection with negative margins. And although invasion is very rare, they all are pre-malignant, and as they are mucinous, and they also got a tendency to recur if you don't remove them completely. So your surgical strategy can either be just an anatomical resection if it's suitable to that. So you've got a cyst limited to a resectable segment sector or hemi-liver. That would be your treatment of choice. Non-anatomical liver resection, or depending on the position of the cyst, you're going to have to sometimes do a partial cystectomy and deal with the back wall of the cyst that you leave, the mucinous cyst, with ablation, mostly argon is described in the literature. There's some reports of ethanol injection again for sclerotherapy in the cyst. I think that's reserved for recurrent cysts and old, frail, non-surgical candidates. In our series, you can see that is over a very long period. At Groote Schuur Hospital, which is a large tertiary center, in 10 years, there was only 13 of these cases operated. So it's obviously not a common pathology. Is there any questions or comments on mucinous cystic neoplasms before we look at something else? Okay. I'm just going to approach it a little bit from a different angle now, because I think this is more useful clinically. We looked at the pathological classification, and that's mostly just to get you to use the new terminology for mucinous cysts. But how you're likely going to encounter these are from a radiological perspective. So if we look at it from that angle, this is a different classification. Well, it's not really a classification, but it's an approach. So first of all, you can evaluate whether it's a single lesion, so solitary lesion, or several lesions, less than 10, or many lesions. If it's a solitary lesion, if it's simple cystic morphology, you would think about if there was trauma, it could be a biloma, seroma, or hematoma. And this is obviously trauma, biogenic or otherwise. History of pancreatitis. You occasionally will get intrahepatic collections related to pancreatitis. If you're lucky, you're going to see 1 or 2 ciliated foregut cysts in the liver or elsewhere in your career. And if it's none of those findings, and it is just a simple cyst. Often on a CT scan, there will be clues. This is a collection after a liver resection. So that is just a biloma. You can see there's our surgical resection margin. There's some clips. There's a bit of a mess. And there is a biloma. If we now look at the complex morphology, so the bottom one, the middle-aged woman we spoke about, they still use the old terminology. Just always keep that at the back of your mind, because you do not want to miss them. If it's not that, it's probably infective or a parasitic cyst, and rarely you'll see some cystic generation of either metastatic or primary malignancies of the liver. Every year, we perk drain 1 or 2. We put a perk drain in 1 or 2 HCCs. Often they present a little bit atypical. The young guys with the hepatitis B-related HCCs, you wouldn't believe that a 28-year-old would have a HCC. They're often sort of mixed cystic, and they get a perk drain. But there should be clues. See, this is a solid cystic type thing in the tail of the pancreas, and if the primary consists of cystic components, then the the metastatic lesions can follow suit on that. I think biogenic liver abscesses most would recognize. We'll talk a little bit about it in the end. But there's I think there's more pictures. There's often clues towards that. It's complex. It fits with the clinical picture. There's a edema around the lesion. You can often appreciate that on CT scan. But just be careful that you don't miss the occasional amoebic abscess. To me, that's you'll get clinical clues. I mean, if you've got this size of amoebic liver abscess, or pyogenic abscess, patient would be toxically sick. Amoebic guys tend to be more chronically ill. They often got a microcytic anemia from the subclinical colitis. And you do see this little bit of reaction around it, this compressed liver parenchyma. That cyst will come to an end. This is a couple of pictures. Surgeons like pictures. You see hydatid sands. You see the endocyst floating around. There's a water lily sign. This is a picture we had in the beginning with a classic daughter cyst scene and bit of central biliary dilatation. That's just for entertainment, a picture. If we go to the bottom, if there's many cysts, there's Caroli disease and Caroli syndromes. We're not going to talk about that. That's a completely different disease. We've mentioned polycystic liver disease and fungal microabscesses. Funny enough, one would think microabscess is a small thing, but remember the true definition of microabscesses is less than 2 centimeters. So any abscess up to 2 centimeters is a microabscess. There's the central dot in Caroli's disease, but then you must have diffuse biliary dilatation. So normally one would get that. More pictures of polycystic liver disease, and there's one associated with liver kidney disease. If we move on to some aspects of hydatid disease, there's 2 classifications for them. One is imaging based, and both of them try to classify these lesions into whether it is active or inactive disease or the maturity of the cyst. It's a Garbi and the World Health Organization. I like the Garbi more because it's 1 to 5 and it's actually quite simple. 1 is a pure fluid collection. 2 is a fluid collection with a detached membrane. And 1 is a fluid collection with multiple septa and or daughter cyst. Type 4 is a hyperechoic with high internal echoes, and 5 is a cyst with a calcified thick wall. In other words, an inactive cyst. Little video, yeah. We've had a visitor in Rowan Park some years ago. Rowan Park is one of the prominent HPB surgeons. He's based in Edinburgh, and he always told me on the ward around, yeah, this hydatid disease looks malignant to him, as it is locally invasive, and it also metastasizes. And in a way, he's right. These lesions, apart from that they're locally destructive, they do metastasize and they do tend to recur. This video again is actually just for entertainment rather than gross hydatid disease. Sometimes we just have to almost physically debulk these patients just to get them to improve the quality of life a bit. A reminder of the parasite. The human is an incidental intermediate host, and it's normally endemic in areas of sheep farming, and then there's a adult form of tapeworm worm. which give the hydatid cyst in the liver. So if we talk about surgical strategy, and the objective for the ideal treatment of threefold. You want to remove the entire parasite. You want to remove or actually manage the residual cavity. You want to have some sort of strategy with it. And you want to identify and treat the biliary fistulas associated with that cyst. There's roughly four treatment options: radical surgery, conservative surgery, pair, which is aspiration, injection, and reaspiration, and there's this long-term parasitic medical treatment. I'm not going to go through all the ins and outs of surgery. I'm just going to comment briefly on it, and then we're going to look at specifics around biliary fistulas. I mean, our standard of care mostly for hydatids, unless it's really localized to a easily resectable, be it anatomical or not anatomical liver, we would not do a pericystectomy or a resection. We will mostly do first sort of a pair combined with a de-roofing and dealing with the remainder of it. I think the morbidity of trying to do that, as that picture there that you see there, a proper pericystectomy is quite high. There's often distortion of the liver. It's often big, and I don't see the benefit of it. You can, if you do it carefully with your sclerocidal agent, you aspirate and inject and aspirate and inject first, and you almost sterilize that cyst first of scoliosis. You can very effectively de-roof the cyst and deal with the induced cyst and deal with the biliary fistulas without a major resection. And that's an operation one can do laparoscopically too, if it's in a accessible part of the liver. What to do with the cavity? I think there is not universal consensus on it, but I think most centers would leave, if there's a piece of mobile omentum in it, you'll plug the cavity with omentum. So let's talk about communicating hydatid cysts, because those are the ones that give us lots of problems. So cystic biliary fistulas is reported in 5 to 25% of hepatic hydatids. The pathogenesis of biliary fistula formation is twofold, due to the pressure necrosis effect of the enlarging cyst on the biliary radicals and the entrapment of the small radicals within the pericystic wall. So you can divide it into two main types: minor, so that's simple or occult, and frank, which is major. A minor fistula is usually asymptomatic and may be diagnosed intraoperatively if you see bile within the cyst, or post-operatively by an external biliary fistula through a drain or wound. A major or frank fistula is a wide communication in the cyst and the biliary system that allows the contents of the cyst to drain into the biliary, causing obstructive jaundice, cholangitis, or even secondary infection. So we always look for which patients do we need to be proactive about a biliary fistula perioperatively or preoperatively, more importantly. The only persistent risk factor published across all published series is the size of the cyst. So big cysts obviously tend to, for both those reasons, tend to be the ones causing the or complicating with cysts. So which of these big hydatid cysts need preoperative ERCPs? Again, there is no complete consensus. If there is a cystic biliary communication, it will reduce post-operative morbidity. So certainly for large cysts, and we mentioned 8 centimeters before for simple cysts, sort of the best available evidence suggests 7.5 centimeter as a last idated cyst, especially the central. If there's echogenic material in the extrahepatic bile duct without shadow, so if you don't think it's stones, but it is stones, probably for a reason to do ERCP too. If there's jaundice, that's a no-brainer. If there's cholangitis, even more so. And we tend to do it for, like the picture you saw in the beginning, if there's central ductal dilatation and abnormal LFTs in the non-jaundice patient. So we tend to be fairly liberal with preoperative ERCPs. There's 4 examples, and you can see the, let's start with the left-hand side upper one. There's some material there in that right-sided, left-sided duct, and there's a subtle fistula, but the biliary tree is grossly intact. Now the other 3 is absolute gross examples of destruction of some of the bile ducts and gross communication with the biliary tree. The problem with doing these, like these bottom 2, if you do an ERCP like this, you tend to infect the cyst with contrast. So if you're going to do an ERCP to manage your potential post-operative bile leak, you should do in the same sitting as you're planning to explore the patient. So they should have finished at least 10 to 14 days of antiparasitic treatment. You bring them in for an ERCP and you do exploration the next day, as you would infect that cyst. And it's very difficult to deal with a infected idated cyst. That's the same reason you can't put in perk drains into idated cyst. The induced cyst and daughter cyst just occlude that thing. It's a complex thing. It doesn't help. So if you've got an infected idated cyst, you normally end up with an emergency operation. So the intraoperative management, if there is a biliary cyst fistula, just remember you need to avoid the sclerocidal agents or contaminating the biliary tree with it. That's why you might sit with a problem of secondary sclerosing cholangitis. So if you aspirate bile or see bile when you do your pair, you should be careful with your sclerocidal. Minor leaks or complications you can identify, you can just oversew with a piece of PDS and do it that way. I tend to routinely run the whole cyst margin where you de-roof the cyst with a continuous suture. As you can do small radicals that's compressed there for a long time with the cyst. And now that you've released the cyst, they will, after a while, produce quite significant bile leaks. Often we will do an air calangiogram, which is quite a handy thing. You mobilize the gallbladder, take off the gallbladder, use the cystic duct with a baby feeding tube to inject air. Sometimes you have to occlude the common bile duct just with your fingers or some pressure on the duodenum, and you see whether there's bubbles. And often you can find subtle leaks like that would have caused you a lot of hassle have you left them. Just to come back to these things, so people sometimes confuse minor and major fistulas with minor and major leaks. So if we talk about endoscopy or ERCP grading of bile leaks, whether it's from whichever cause, a minor leak is one that needs pressure to opacify. In other words, you need like that top left one, you need occlusion, you need a balloon to opacify it, or you need the intrahepatic ducts to fill first before you see the leak. So that's a low grade leak, and a high grade leak would be a leak that opacify on imaging before the intrahepatic ducts or without the occlusion at the bottom. So you'll just inject contrast and like that bottom one, and you'll see contrast extravasation. Every now and again you'll see with these destructive adaptive diseases that you will need to do a biliary enteric reconstruction. And that's a particularly bad one. If you see that picture number 2, there's drains, and it's actually just cut blood drains because they're nice and soft into the left and right duct. So this whole hilum was destroyed, and then you have to do a biliary enteric reconstruction. And our default obviously is not dissimilar than other reconstructions. Is a Roux-en-Y limb, where you do a reconstruction that way, and you can see we sometimes try and connect the left and right duct in the middle. Otherwise, you must do 2 separate anastomosis. I think just the last 2 slides or so on biogenic liver abscesses. Otherwise, we haven't completed a talk on cystic liver disease. It's common. It has changed sort of in the last 30 years or so, where the commonest etiology was polypyema, so diverticulitis, pelvic sepsis, appendicitis, those kind of things, to cholangitic abscesses, so hepatobiliary causes, often related to procedures now, ERCPs, hepatobiliary surgery, etc. And then don't forget about the other 2 routes, arterial and traumatic / adjacent abdominal pathology. There's not a well-described microbiome for biogenic liver abscesses, and neither is there anywhere a consensus on antibiotic therapy. So it's often guided by local policy. But E. coli and Klebsiella would obviously be the commonest bacteria you expect. In terms of treatment of surgical treatment of biogenic abscesses, so obviously antibiotic therapy ASAP. In stable patients, you're going to do some cultures. In multiple small lesions, even if you can't do anything else, it's nice to do a final aspiration that you can have some sort of microbiology. Lesions smaller than 50 millimeters can usually be treated without a drain. You can just aspirate it and treat antibiotics. And bigger ones, or if you establish that there's some sort of biliary communication, one should leave a percutaneous drain. This is also a common concern and question on how long you should continue treatment and how do you measure response on treatment. For me, it's a clinical thing. Imaging can take a long time to change. So that cavity in the, and certainly the cross-section imaging appearance of a cavity takes a long time to change. So if the patient does clinically well and is stabilized clinically, one can switch them to oral antibiotics. And often the recommendation is to continue for quite a while, up to 4 weeks with antibiotics. Just on that note, remember, if you put a percutaneous drain for a liver abscess, in fact, any drain that goes percutaneous into liver, there's only 2 times it come out. It's day 1. So if you do like a FNA or in and out BTC, you can take it out on the first day. Otherwise, you must leave it for 10 days in order to form a tract. The reason for that is if you can potentially have a small leak of either bile or, in this case, purulent material between the peritoneal lining and the liver. So if you put in a perc drain, leave it in. That doesn't necessarily mean to say the patient needs to be in hospital, but leave that drain in for at least 10 days so that you can form a tract, and the fistula will slowly close. I think surgical treatment of biogenic abscesses is something that's not done often, but the Bridesmaid's indication indicated for obviously failure of medical or non-operative approaches, or if the patient is quite sick with intraperitoneal rupture, and these patients that need surgical intervention for the cause of the abscess, like appendicitis, diverticulitis, etc. It's also a little bit of a different pathology, but sometimes it is necessary to do some resection for chronically infected livers, but that's more in a setting of hepatolithiasis and complex strictures, which is a little bit out of the scope of the practice of this talk. I think we've covered most aspects around cystic liver lesions, and I've deliberately, I think I've left about 5 minutes or so, and maybe we can talk about some of your questions or experiences, etc. Any comments? Colin. Let's see.
Hello.
Hello.
Hello, do you hear me?
I hear you. I can hear you.
I was thanks for the presentation, for the cases, nice case, and the very nice algorithm of management. My question is, how do you approach an extensive hydatid test with kind of intra-abdominal rupture and intra-abdominal hydatid cyst?
So if I understand your question correct, you want to know approach to extensive intraperitoneal spread of hydatid.
Yeah.
Yeah, it is. I think there's not a lot of elegance around that. We debulk them as best we can, so it's mostly open surgery, and you, if they're surgical candidates and you addressed all the cysts, we would do combination of pairs, so aspirate, inject, aspirate, inject, and de-roofing of all cysts. So often they sit in the pelvis, often they sit in the left upper quadrant around the spleen. Often the spleen comes out with them. Sometimes it's quite challenging in women, if they're in the pelvis, especially young women, because you've got this pelvis full of cysts. You don't know what is what and what is ovaria, what not. But in principle, we surgically debulk them as best we can. But I assume you asked the question because you has had these struggles. Any more comments or questions? Okay. I think then we're going to call it a day. Just thanks again to ECHO University of New Mexico and the ECHO India team for the support. Please just remember about the feedback form available in the chat. The recording of this presentation and all our presentations will also be available on the Gastro Foundation website. Thanks to Gastro Foundation for that. Next week, a colleague of ours, Dr. Adam Boutal, will talk on intestinal failure next week, 27 June. Unless there's anything else, I thank you and have a good evening.
Thanks very much, Christo. Bye, everyone.
Thank you. Bye. Thank you.